regard to some of my own clinical experience and in regard to side effects, I mean, fortunately, both allopurinol and rasburicase are relatively well-tolerated medications. So for example, I see a large lymphoma population. If I have a patient who is going to be a relatively standard risk diffuse large B-cell patient, not necessarily a massive tumor burden. LDH might be elevated, but again, not a large tumor burden. My routine in those situations are to prophylax with allopurinol and make sure that the patient is well hydrated, and that I will be monitoring their laboratory values on a daily basis. In my more aggressive patients, who, again, an acute leukemia or a patient with a refractory lymphoma, which is probably another good case where they come in with a large tumor burden, and they actually might even have a leukemic phase to that, where they have lymphoma cells circulating in the blood, or it's taken on a more even aggressive high-grade histology. I'm going to be thinking about rasburicase, maybe not prophylactically, but I'll be thinking about the early intervention. If I see that I'll prophylax with allopurinol, I'll have them in the hospital, I'll be giving them aggressive IV hydration, but I'll be quick on the trigger to using rasburicase. And then in my leukemia and my really super high-grade lymphomas, which require hospitalization for the initiation and treatment, I'm going to be thinking about rasburicase prophylaxis. Allopurinol, coming back to side effects, there can be hypersensitivity reactions to it. It's relatively rare, and in those patients, if you start seeing anaphylaxis or a skin reaction, you just stop the medication. But those, again, fortunately, that's a less than 5% incidence. With rasburicase, there can also be an allergic reaction and anaphylaxis, but again, very, very rare circumstances, less than 2%. One thing that you do have to worry about is if a patient is G6PD deficient. This is seen more commonly in patients of African or Mediterranean ancestry. So again, a relatively low incidence, but and you really, in that situation, if you really think that you need to use rasburicase, you have to weigh risk and benefit, and usually the risk, if you're thinking about you're needing to intervene for a patient who's developing clinical tumor lysis syndrome, will outweigh that. If you're using as prophylaxis and you have a little bit of time, please try to get a G6PD test. And again, that patient population of Mediterranean or African descent are the patient population. You can do that. And some patients have known G6PD deficiency. Rasburicase can also cause an entity known as methemoglobinemia. And so just be aware of that while the patient's doing it. All of a sudden you see a rapid drop in their hemoglobin, and you don't think it's from the chemotherapy. That would be another indication to stop rasburicase treatment.
I tend to focus on patients with chronic lymphocytic leukemia where our therapies are effective. And so because they're effective, there is a risk of rapidly killing off tumor cells. I think that both rasburicase and allopurinol have a place in the clinic, and that it really depends on the factors that I mentioned earlier that helps to determine who needs what agent or both agents and how they should be given and how they should be dosed. I've had a very favorable experience, and I think if you follow the guidelines closely, the risk of developing clinically significant TLS is quite low. And so you want to use these as tools to prevent the event from happening, but if it does occur, I've used rasburicase many times to lower the uric acid, and it works very effectively. Rasburicase could either be used for preventing an event or managing an event. If you're giving it as prophylaxis, you don't have hyperuricemia, you're trying to prevent it from getting to the point where you have an elevated uric acid level. If you're treating hyperuricemia, then that's a different story. You can have an elevated uric acid in the setting of spontaneous tumor lysis, but the mechanism of action and the dosing and the monitoring is not changed based on the use of the drug.
My experience using rasburicase is really been in these more aggressive patients with advanced leukemias and advanced lymphomas. One of my particular area of interest is in refractory lymphomas, and I have in those patients who have unfortunately developed hyperuricemia. The success rate with rasburicase, it's very impressive. Within 24 hours, the uric acid levels just dramatically drop. And one important aspect, and for physicians to remember, that when you are monitoring for uric acid, you've got to make sure that you take the samples and that you actually have chilled tubes that contain heparin, and you put those tubes in a water-based or an ice bucket. A lot, commonly your nurses will use like a water jar and full of ice with water in those samples, because rasburicase, if it's left at room temperature, is still working. So you may get falsely low levels of your uric acid, and you really need to be following those levels. So it's just an important thing among oncologists and hematologists who are monitoring for tumor lysis syndrome. But again, my experience has been that the medication is very dramatic in its ability to lower uric acid levels, and I've been highly happy about it because we haven't always had rasburicase around. I'm unfortunately very old, and to see this have this new, relatively new medication in our armamentarium to help us in both the prevention and treatment of tumor lysis syndrome has been quite satisfying.